Transmitting live to our international audience from the Farah Medical Campus here in Amman, Jordan. The topic for tonight would be petroclival meningiomas. So we need to discuss what is petroclival, which area the skull base is that, and we'll discuss the meningiomas in that part. So anatomy again for any neurosurgeon is a must. You cannot mention anatomy of the nervous system without mentioning Albert Rhoton from Gainesville, Florida. He's the master of anatomy. He taught us anatomy that we did not know before. And I'm really proud that I knew this man very close. He passed away 3-4 years ago. So these are the bones of the skull base. This is the sphenoid bone. This is the temporal bone, the occipital bone. They join together. So this part of the temporal bone joins this, which is the clivus. So we're speaking of petroclival. So this is skull base, anterior fossa, middle fossa, posterior fossa. This is the temporal bone in relation to the clivus. Again, this is the clivus. This is the petrous bone. They make connection here. And you can see the cranial nerves and the skull base. So we classify the clivus into upper, middle, and lower clivus. Upper zone, middle zone, lower zone. And there is an angle between the clivus and the petrous bone. So it is not flat, there is an angle. And that makes it difficult for surgeons. This angle is to be appreciated only by people who work there. This is small, few centimeters in length, few centimeters in width. بالعربي اسمها المنحدر, clivus, يعني المنحدر. It's a small bone, but everything is there. Abducent nerve, trigeminal nerve, 7th, 8th nerve, and the lower cranial nerves and the hypoglossal nerve. All condensed in a small area. Again, this is a picture I took when I was training at Albert Rhoton lab in Florida, and this is a picture I took myself from one of the cadavers. And this teaches you well. Nothing can teach you anatomy and how to use this anatomy in surgery except if you do cadaveric studies. Again, two basilar arteries joining to form two vertebral arteries joining to form basilar artery, and the branches, the pica, the ica, the superior cerebellar and posterior cerebral artery, the relationship of the nerves, the 6th nerve, trigeminal nerve, 7th, 8th, lower cranial nerve, 9th, 10th, 11th, and the hypoglossal nerve. So that's the picture that you would like to imagine in your brain, in your mind, if you want to operate in that area. The lesion is here between the petrous and the clivus, so it's here. Imagine somebody putting you something there and is asking you to remove it. So you have to keep this image of where every structure is. Again, 7th nerve, trigeminal nerve going to Meckel's cave, 7th, 8th, 9th, 10th, 11th, and hypoglossal. If you look at it from above, you will be working here. This small space there. Magnify it, you'll be working here between the petrous and the clivus in this angle. Again, you have to picture it in your mind, not only the arteries, the nerves, brainstem, cerebellum, but also the venous sinuses. This is called basilar venous sinus. This is the inferior petrosal sinus, superior petrosal sinus. This is the sigmoid sinus. And when you come to the clivus and petrous, if you remove the dura, you will also have this plexus of veins there. So it's a complex anatomy that anybody who wants to operate there must be mastering it. Same picture, abducent, trigeminal, 7/8 lower cranial nerves, hypoglossal. Looking at it from the side, you will be working here. In this area, where every important structure is, the crust of the midbrain, the arteries, the nerves, and everything. trigeminal nerve in the Meckel's cave. And these people taught us about the anatomy of that area. Gruber, Gardening, and Dorello. They gave us these names that we need to know. So this is the clivus, this is the pituitary, third nerve, fourth nerve, sixth nerve, sorry, abducing nerve, and the plexus. Another beautiful paper by Pablo Kabebenka and Majid Sami of that particular area. So you see the trigeminal nerve, underneath it is the carotid, this is the Gruber ligament. If you remove the trigeminal, you will find the carotid artery and the Gruber ligament. If you remove the Gruber ligament, you will see the Dorello's canal through which the sixth nerve passes. It's no more acceptable that patients should come out with cranial nerve disease. In the past, oh, it's a brain surgery, so if the patient dies or hemiplegic is acceptable. It's no more acceptable. So these papers construct our anatomical knowledge of this particular area, the trigeminal nerve. What's the relationship with the petrosal sinus? Is it underneath it? Is it above it? Or is it enclosed between those two areas? So we know now what is petroclival. Let's speak about meningiomas. Harvey Cushing, the father of neurosurgery from Harvard. This is the period that he lived. He classified these, he gave the name of meningioma. He coined the name meningioma. So the meningiomas could be anywhere. They are the most common benign tumor in our brain. So we should know it. Supratentorial above the tent, 90%. Below the tent, 10%. This is the tent. So when we speak about petroclival meningioma, what are we talking about? Is this area or this area? People differ in their explanation, and we'll go through that. So people agree now, and I'll give you the final ultimate agreement that it is medial to the cranial nerves, 5th, 7th, and 8th. So we're talking about this. And the upper 2/3 of the clivus. Lower clivus is not part of this. Lower clivus is foramen magnum. So upper 2/3 of the clivus, medial to the nerves. So we're talking about this area. So people like William Caldwell from Salt Lake City with Fukushima, Takanori, Taki, again, they say this is the area where the petroclival meningioma arises. William Shaker from Seattle, United States, he said, if the meningioma arises from petrous ridge medial to the internal auditory meatus, it is called petroclival. So anything medial to the internal auditory meatus is called petroclival meningioma. Majid Sami from Hanover, Germany. I talked about him a lot because he's the man who gave us our knowledge about how to operate in that area. He said, well, let's agree. Infratentorial meningiomas are either in the cortex of the cerebellum. Cerebellum has 3 surfaces, the occipital surface, the tentorial surface, and the petrous surface. So the cortical meningiomas, and then the lateral petrous group, and then the cerebellopontine group, and then petroclival. So there's a huge difference between petroclival and cerebellopontine meningiomas. In the Arab world, in the third world countries, these are all amalgamated into meningioma of the cerebellopontine angle, which is wrong. Cerebellar convexity meningioma. This is convexity meningioma. This is a paper by Michael Sergel from San Francisco. This is called, it's not petroclival, it is cortical. So even the nomenclature is not correct. This is cortical, these are my cases. This is cortex, so cortical meningioma, superficial. Majid Sami said, well, cerebellopontine angle meningiomas are the next group. They are centered around the internal auditory meatus. Either they are before it, or centered on it, or they are behind it. So let's look at that. Post-meatal, so behind the meatus. Look at this. This is the meatus, and this is the tumor. So this is behind or post-meatal. Centered over. This is the internal meatus centered, and you may easily miss this for a vestibular schwannoma. It is a meningioma centered over the internal meatus. These are my cases. Centered over. Again, all these cases I'm showing are my cases. Look at this here. If they are centered around the meatus, they could be above it or below it. So we're speaking about suprameatal, above the meatus, or below the meatus, inframeatus. So petroclival meningioma is totally different from the cortical meningioma, from the lateral petrous meningioma, from the meningiomas that are called cerebellopontine angle, which are having relationship with the internal meatus. So look at this, we are medial to the internal meatus. This is a true petroclival meningioma. You can call them clival meningioma. So Majid Sami said, meningiomas arising from apical petrous bone, upper 2/3 of the clivus, medial, not medial, medial to trigeminal nerve, are petroclival meningiomas. And they constitute 5% of the meningiomas. But they can extend. They are not only there. They can go to Meckel's cave. They can go inside the internal meatus, go to jugular foramen. They can go to foramen magnum, and any combination of the above. Here, the meningioma went into the jugular foramen. Here, it went into the internal canal. Here, it went into the cave. Or it can overflow. Look at this, it's overflowing to everywhere. Again, these are my cases. Sometimes they are lost for definition. What would you call this? Petroclival or clivus or cavernous or whatever. So this is the image that people should have in mind. This is a petroclival meningioma found in a cadaver. And this is the relationship with the brainstem and with the nerves. So you have put something in front of everything. Look at this relationship of these meningiomas with the structures that we mentioned. What's the natural history of these meningiomas? So the natural history suggests that they progressively grow with progressive neurological deterioration and death. This is the natural history. So you have to go for excision to provide the only chance of a cure. No other way of treatment will give you a chance of a cure except surgery. And these lesions, they grow. So this is one meningioma. This is 4 years later, no change. 5 years later, no change. 6 increased, 10 years increased. So they tend to grow. Having said that, this paper from Germany, this calcified meningioma remained the same after 7 years. So there are odd cases. In my series, I discovered this petroclival meningioma, and this lady continued following her up and did not change whatsoever. What's the management? You may observe, you may do surgery, you may give radiotherapy. Let's discuss. When do you observe these cases? If they are small, asymptomatic, or found incidental, or medically unstable, you are given the chance to observe. Surgery. This is recent. Up to 1970, they were inoperable. People would not even think of doing surgery for them. And then things with the signs and symptoms. Yes, they grow with signs and symptoms. If the patient has, yes, simple, like simple headache, and slight numbness in the face, and it is not increasing, yes, we would wait. So complete surgical removal is the optimal treatment. But this should not be achieved at the expense of the patient. It's not I am the courageous Superman neurosurgeon. I want to remove the tumor so that I will give you a good picture. I have to respect the patient. I should not be courageous on the expense of the patient. But my aim is to remove it completely, if I can. So, not to remove totally, regardless, but to attempt complete resection by optimizing the surgical conditions. So it needs a good anesthetist, it needs a neurologist, good neurosurgeon, good oncologist to do this kind of surgery. Gross total resection is reported in about 50%. Why gross total resection? This is Simpson grade 2, not Simpson. Nobody can achieve Simpson grade 1 in the posterior fossa. But gross total resection is reported in more than 50% of patients. Papers, Germany, 97. This is Johann Stramm, the chairman of the German Neurosurgical Society. He's retired now. Look at this. Radical excision. Radical resection is always the best option. The answer is yes, except for piece that is going into the cavernous sinus. We do not operate on meningiomas going inside the cavernous sinus. We learned that we cannot cure them. But anything else, we should remove. How do you reach to that area, difficult area? So many approaches, retrosigmoid, petrosal approaches, translabyrinthine, transcochlear, middle fossa approaches. So these are the many approaches that has been invented. Look at this. You have to imagine how to reach that. You want to reach here. So subtemporal, transpetrosal, retrosigmoid, and so on. Paper 92, Miriam Shaker from Seattle. He used the subtemporal approach. 92. Subtemporal approach also was described by other authors. Large and giant petroclavian meningiomas have the choice of microsurgical excision. Again, subtemporal, you go underneath the temporal lobe, you incise the tentorium, and you can remove them. Petrosal. This is petrosal, superior petrosal sinus. You can come this way called anterior petrosal. You can come this way called posterior petrosal. And it is named after Kawase. Kawase is the Japanese neurosurgeon who discovered this approach by accident. He would tell you that he was doing some drilling in the cadaveric lab and he discovered that he can remove this bone without making any problem. So he published this paper, Kawase 91, anterior transpetrosal approach. So this is meningioma, comes anterior petrosal and remove it. This is Takeshi Kawase. I'm proud to, again, be a member of the so many groups that skull-base surgery in the world has achieved. Here we are in the Asian group, here we are in the international groups of the skull-base surgery. He's a great man, and his wife is a great woman. This is when he invited all of us to Mount Fuji. So this is the World Federation. Pre-sigmoid, which is the posterior petrosal approach. So you come from behind. And this was championed by Al-Mufti, Hussam Al-Mufti from Syria, who immigrated to the United States. He's one of the big shots of skull-base surgery. And he put this into papers, 2009, how to do the posterior petrosal. And again, another approach by Al-Mufti. Also describing the findings, what are the structures that you will find and how would you see them, how would you vision these approaches. He would do combined petrosal, anterior and posterior petrosal, for some difficult cases like this, the so-called declival meningiomas. And he described in this beautiful illustration done by artists. Every department should have anatomical artist. So that I, as a surgeon, I would come out and tell him what I think, and he would give it to me in drawing. This is totally lacking in the Jordan, Arab world, and the Middle East in general. But he came out and he said, some melangiomas like this, they have arachnoid between them and the brainstem, double layer of arachnoid, beautiful. He would tell you, give me 100 of these, don't give me any one of these. Why? Because there is only one plane of arachnoid between the tumor and the brainstem. Here there are double arachnoid. And that's a Mufti, again, close friend. And we are in one group called the World Academy of Neurosurgery, and we're having our meeting in Brazil in a month's time. Other people followed. Kenji Ohata from Japan also described the Petrosian approach. So they are masters, and we learned from them. From China, the same thing. You would think this is impossible to remove. It is impossible in the hands of mediocre surgeons. That's why they go for Gamma Knife. They don't go for Gamma Knife because it is better. They go because it is the only thing they know. They know nothing else. Retrolabyrinthine approach from USA. Abekidis from Cleveland Clinic. And my friend Volker Siffert from Germany describing this approach. Again, the same approach like Majid Sami. Retrosigmoid, again mastered by, as I said, Majid Sami. And he would tell you these items. Surgical resection continues to be the first and best treatment. Treatment goal should be complete resection, which is the only potential curative option. We believe, his group, that the petroclival melangiomas are best removed in the simple and safe retrosigmoid approach. He does not want to go into pre-sigmoid and combined sigmoid. Retrosigmoid for him is enough, and I personally believe in this and adopt it. So this is the picture. Retrosigmoid, you drill the suprameatal bridge, so you see more, and you see these nerves in a good fashion. Another paper from Japan, the same approach, retrosigmoid. So you can really, here they are putting, this is for neurosurgical residents and young neurosurgeon, they put this to avoid adhesions. Retrosigmoid. So to me, retrosigmoid is the workhorse for these kind of tumors. This is from Anil Nanda, United States, Indian chap. So surgery is, the aim is total. But when you go there with this aim, with this determination, I want to cure the patient by removing this tumor, and you fail because of circumstances that it is stuck to the arteries or nerves or whatever to the brainstem, then you accept defeat, you do subtotal, and then give radiosurgery. So this is only done after this or this. Some people would say, and this is a trick by the so-called mediocre neurosurgeons practicing radiosurgery, oh, it's big, so we cannot treat it. Everybody will blame us. So why not go and remove part of it, and then the rest we will give Gamma Knife. This is wrong. And this is a statement from Majid Sami. An approach that starts with the idea. You start with the idea of subtotal resection, and then radiotherapy does not serve the patient well regarding chances of a complete excision. So it is the state of mind. So the primary goal before surgery should not be subtotal excision. Otherwise, this will lead to inappropriate surgery by inexperienced surgeons with significant morbidity and compression of brainstem. There's severe compression of the brainstem, and they still give Gamma Knife. You say, come on, Gamma Knife starts, you give it today, starts after 6 months, completes action in 2 years. Why should you keep the patient brainstem compressed for that period of time? They have no answer, except they push the button and take the money. So what's the histopathology of these tumors? Sam?
Good evening. Petroclival meningioma actually is not different than other types of meningioma. So we'll go on what is the typical histology of meningioma. This is the most common histology that we see in meningioma, which is the meningothelial meningioma. And you see it as cartwheel appearance with pseudomorph bodies. Some of them are calcified. This is higher power. You can see many pseudomorph bodies because these are ancient changes. Pseudomorph bodies indicate dead cells that are calcified because of the ancient changes that are called long-standing meningiomas. And the more pseudomorph bodies usually indicate probably the more progressive, innocent meningioma or ancient meningioma. Sometimes you can see spindling fibroblastic pattern, and this can be seen usually more in fibroblastic type meningioma, as you can see here. Sometimes you can see dense because of hyalinized cells, as you can see here, very usually hypocellular. In this area, it's really converted almost to hypocellular or acellular areas because of the very slow growing and avascular supply to this area. Typically, all meningiomas should have epithelial membrane antigen positivity, but it's very important you have to recognize the pattern. Usually it is multifocal, it's not in all cells as you could see, and usually it is membranous in around membranes. Why I say you have to emphasize, because there are other tumors that can be positive in epithelial membrane antigens, for example, like ependymoma, but they had much different pattern than meningioma. So it's very important you, as immune staining, not only to call it positive, but also to recognize the pattern of immune staining. Progesterone, usually most of these meningiomas, especially if they are grade 1, they are usually progesterone positive. And usually the more progesterone positivity, the better prognosis. And we have publication about progesterone as one of the good prognostic factors and grading for meningioma. P53 usually is negative, even in the atypical meningiomas, but when it is positive, it's bad prognosis. KISA7 usually in low-grade meningiomas or grade WHO or grade 1, in our publication, it's usually 1.51%. If it is the grade 2, usually is 5 to 6%. If it is anaplastic, it may reach up to 20%. So this is usually we call it a fibroblastic meningioma if it is WHO grade 1, and there are other types of meningiomas. This is one of the publications that we have predictive markers for meningioma grading, how to grade meningiomas. We use the tumor size. You can see as you go from grade 1 to grade 2 is not much, but grade 3 usually they present with much larger tumor size. These are all our cases, Dr. Ibrahim and me cases. Atypia is more common. You can see even in grade 1 you can see some atypia, but they are usually few number of cells. But you can see in grade 3 most of the cells are atypical. Small cell component can be seen in usually most of the time in grade 2 and other than other grades. So it's usually one of the features that is atypical meningioma, not the benign one. Brain invasion usually is not seen by definition in grade 1 and is seen in grade 2 and much more common, or almost all cases that we have in a grade 3 or anaplastic meningioma, they have brain invasion. So brain invasion is an ominous sign. It used to be a WHO classification in the 90s that they consider when brain invasion, this is called malignant. But they discovered, no, we really have to not consider it as being malignant. It can be grade 2 and still have brain invasion. And this is support our study. Bone invasion, this is actually very important. And I mentioned to one of the famous neuropathologists that came to Jordan in the Dead Sea, he attended this lecture. So I told him that bone invasion in his definition is not a case of grading of meningioma. But I mentioned to him that this in our study, we had it, it's more common in grade 3 compared to grade 2 compared to grade 1. And then he commented on that. He said the Japanese and the European consider this is part of the grading, but the American, they don't consider it. So I think probably it's right to consider bone invasion. That's why I always emphasize it in my report, whether I see bone invasion or not. because after studying this, I think it's one of the important things to mention. And when there is bone invasion, usually this patient maybe have more chance of recurrence. Necrosis usually is seen in more in higher grade meningiomas in our study, almost half of the higher grades, but it's much less in lower grade, and the pattern also is different. Usually necrosis in the higher grade meningioma is geographic type necrosis, as if somebody is writing, is drawing a map, but in the smaller grade or lower grade, it's usually spotty, just small spots of necrosis. So it's very important not also to mention the necrosis, also to mention the pattern of necrosis. Mitotic count also is very, very important. Also, this is one of the things that I differ with from the standard neuropathology WHO classification. I told him that we found that grade 2 usually mitotic figures is 1.2 in our cases, and this is an actual study. While the WHO consider 4 or more mitotic figures to classify it as 2. I think with 4, probably we are missing some cases of 2 and undergrading them as 1. So I think we should really not consider 4 mitotic figures as the point of differentiation between grade 1 and grade 2, but still WHO consider it as a grade of 2 is 4 and or more. B53, most of the meningiomas actually are negative for B53, even the higher grades. You can see even the higher grades, usually they are negative, but when it's really present, it's more present in the higher grades. B63 also, B63, we differentiate between whether it's nuclear staining or cytoplasmic staining. Cytoplasmic staining is not much of importance in the grading, but when it is nuclear staining, it's more common in higher grade meningioma. Progesterone, the other way around, it's inversely related to meningioma grading. The more progesterone receptors percentage, the better grades. You can see in grade 1 reaching up to 90%, grade 3 most of the time it's really negative. Ki67 that we mentioned in grade 1 usually it's 2.9 in our, it's the 6th grade 2, and it's very, very high in grade 3. We always use Ki67 in all our cases, and I think it's very important. Still now, WHO does not consider Ki67 part of the grading, although they consider it in the calling it whether it's grade 2 or 3 or 1, but not part of the criteria. I think probably is going to probably change because there's not much data, but our study confirms that Ki67 is really very important. In our study, low grade more common in females, but higher grades are more common in males. Atypia, small cell component, necrosis, bone invasion, brain invasion, necrosis, more common as you go from lower grade to higher grade. Mitotic figures, and I think this is very, very, very important in my opinion. In grade 1, you can see some mitotic figures, but usually very less than 1. In grade 2, you can see is mitotic figures by 1.2 to 2. So I think any mitotic figures should be taken seriously. I don't think we have to wait really for 4 mitosis or more to call it grade 2 or grade 3. And grade 3 usually is higher mitotic figures. Markers like B53, B63 are more in higher grades, progesterone in lower grades. This is an important also. Ki67 is much higher in higher grades and lower in lower grades. Thank you.
If the take-home message tonight is to convince you that meningiomas are nasty tumors, then I have succeeded. Meningiomas are not benign lesions. Because if you can tell me one tumor in our body, in the human body, where when you remove it completely, it is a grade 1, that it has a chance of coming back again in 10% of cases, then meningioma is not benign. Other than surgery, we can do endoscopy. And these are the famous endoscopists around the world: Charles II, Amin Kassam, Snyderman, Gardner, Gap, and Schwartz. And as I said, they produce beautiful anatomy. Like when Roton gave us the beautiful anatomy of microsurgery, these people give us the beautiful anatomy seen through the endoscope. So they have gone anteriorly, they have removed the clivus, and they are looking front at the basilar artery in the front of the brain stem. Beautiful anatomy. So they started removing some of these tumors in this place. Also, they mentioned and discovered and reported the endoscopic anatomy of the arachnoid, which is again give us further insight into what to do. Endoscopy is endoscopic endonasal or endoscopic anterior petrosectomy or endoscopic retrosigmoid. So they have different approaches, and these are the papers published for removal of petroclival meningiomas. Can they remove it like in microscope? The answer is no. But it is for the future, and this is the future of neurosurgery. Again, midclival meningioma, not removed completely, but it is an attempt, because this is how the science is progressing. If we just let things be as in the past, we will not progress. This is how to push the envelope, by discovering the new methods. Again, clival meningioma, by endoscope, still they have left some piece, but that's okay. In the future, they will succeed. Again here, leaving some. So different approaches using the endoscope for these tumors, using the endoscope in the retrosigmoid approach. And again from Italy, again this is from Paolo Cababianca and his group in Italy. Petroclival meningioma using the endoscope. So what is the difference between microscope and endoscope? Microscope is 3D. Endoscope at this moment is 2D, but they are working on 3 endoscope. So once that is done and it is popularized, thing will explode. Learning curve of endoscope is longer. The corridors you are working through are narrow because you are using the endoscope. You may cause vascular injuries, and if you do, then you cannot repair it because you are in a narrow corridor. So difficulty controlling bleeding. Tumor consistency, if it is hard, you cannot remove it. You actually open the dura, so you will cause CSF leak. And there is some destruction of the nasal anatomy. These are the drawbacks of endoscopy, but they are going to improve in the future.
But wouldn't the drawbacks of inability of controlling bleeding the way a surgeon would like to be a major hurdle for this?
Absolutely it is. Absolutely. No doubt about
Because
it.
no matter how good the surgeon is, as you very well know,
You can't.
bleeding
Yes.
will happen. So.
Absolutely. And they have seen this when they're using the so-called supraciliary approach, using the endoscope to clip an aneurysm. And then the aneurysm rupture, and then you have to convert to formal clinician. By that time, patient is lost. So endoscopy in general is restricted because of so many factors. So it is maybe used for a small midclival meningiomas. And that's Carew, who's a famous endoscopist. Most recent studies of endoscopy, meningiomas are anatomical studies still there, mostly anatomical rather than clinical. Use of endoscope is not superior to microscope in posterior fossa. Still controversial. That's by Amin Kassam from Pittsburgh. He moved from Pittsburgh actually. Placing an endoscope, inserting and withdrawing, inserting and withdrawing through the cranial nerves is a blind process and carries high risk. That's by Theodore Schwartz from New York. The corridor between internal determinatus or canal and jugular foramen must not be entered by endoscope by Michael Gabb. So it has a place, but its place definitely lies in the future. What about radiotherapy and radiosurgery? Don't give radiotherapy and radiosurgery upfront. It's not good. Everybody says that repeatedly, but those people would not listen. Radiotherapy mainly for these meningiomas would be proton therapy, and proton therapy is only available in 4 or 5 centers around the world. Remember, radiotherapy or radiosurgery carries the risks that we know, but we still use radiotherapy and radiosurgery. But don't use it as the first line. These are the cases treated by radiosurgery. Radiosurgery for para-internal retrocanal meningiomas. Look at this here. I think you can read or not. 6 months, 12 months, 24 months, and so on. Do you think there's any difference between this and that? They say this is control of the tumor. Control what? The tumor is still the same. Examples. Gamma knife, 2 years after. Oh, the tumor has shrunk, but it's still there. 5 years, tumor is still there. 2 years, tumor is still there. These are published papers from major centers. This is from Charlottesville, Virginia, which is considered one of the major centers of radiosurgery. France, by John Regis from Marseille. Gamma knife for this tumor causing pressure on the brainstem. Still they give it, gamma knife. You say, people, there is severe pressure on the brainstem. Your gamma knife will start acting after 6 months, complete its action in 3 years. You cannot leave the pressure on the brainstem like this. We don't care. That's the answer I get in conferences. We don't care. 1 year later, still the same 7 years later. As I said, they don't use the gamma knife because it's better for the patient. They use it because it is good for themselves. Look at this tumor and look here. There's no more brainstem. It is severely compressed. After 5 years, it's still compressed. They show you pictures, but we don't know what the patient is doing. Look at this and this. Can you tell any difference? No. This and this. After 4.5 years, we control the tumor. You did nothing, actually. Look at this. This is really nice. Decreased calcification. Decreased calcification.
Brilliant new endpoint.
Absolutely. And this is by Jason Sheehan from Charlottesville, major radiosurgery center. Look at this. That's the brainstem compression. This is the tumor. Still, they're giving it the gamma knife. I don't comprehend this. I would not ever prescribe to this way of doing things. Then they said, well, let's do surgery. This is big tumor. They would blame us if we treat this big tumor. So let's do surgery, remove part of it, and the rest we will give gamma knife. What is the end result? Very bad. Konziolka, again, a major center in USA. What does it say? Radiosurgery should be considered as an initial option for small volume, small meningiomas. I agree to that. If the patient is not fit for surgery, but they don't. They treat patients across the board. Again, the same center, small retroclavian meningiomas. Of course, if they are small, they are good for surgery. Why should I give them radiosurgery? If they are large, it is not good for gamma knife. So both small and large, you should not be giving gamma knife. Again here, Dade Lansford, Flickinger, and Konziolka, the same center. Resection, they accept and they admitted resection is the first line option for these meningiomas. But during the last 20 years, stereotactic radiosurgery has become an alternative option. It is an alternative option for those patients who cannot have the surgery because they are medically ill, very ill, or very old. Oh, okay, what can we do? They come up with another trick. Let's give staged radiosurgery. Radiosurgery is to give the dose in one session. So you give it now, within 2 hours, you give the 20 grays or 30 grays, or in case of trigeminal neuralgia, 90 grays. So they say, we'll give radiation now, and 5 months later, we'll give another dose. Another stupid twist of mind. Because this is radiotherapy, it's not radiosurgery. We mentioned that. So I'll come to my series, retroclavian meningioma from January 90 till 18. And why 18? Why not consider the rest of 2018, 2019? Because you have to leave 2 years for a meningioma for a follow-up. You cannot include cases that you have done yesterday or the last year. And there they are. Each and every single case of them. 116 cases. But 34 patients were lost for follow-up, so I cannot present them. I have done the surgery and they disappeared. So how can I tell what's the result of my surgery? So we're left with 82. But 28 had short follow-up. To present meningiomas, you have to have long follow-up. And this is always we criticize radiosurgery that you have short follow-up. So we'll not fall into the same trap. So we say we will not include these because they have short follow-up. So 54 had long follow-up. And these are the cases that I'm presenting. 54 of petroclival meningiomas that I operated and followed for long, long years. I'm talking in some cases 20 years, 15 years, and so on. Females, more than males. This is a known fact. Meningiomas are commoner in females. And the reason is because they have estrogen and progesterone receptors. And the fact that meningiomas in female, the second and third trimester of pregnancy increase in size is well known, except in the Arab world and Middle East. Patient who is pregnant gets blind, they gets whatever. They say, oh, this is toxemia of pregnancy. They never think of meningiomas increasing in size during pregnancy. So like other centers, like other publications, females in my series is more than males. And as Dr. Farsakh said, females, they have grade 1 more, males have grade 3 more. So we're equal. Again, back to Kawase, Takeshi Kawase, he described this in his paper. He said, let's classify these petroclival, not haphazardly. We'll call this upper clivus, this is cavernous sinus, this is the tentorium, this is petrous ilex. So I thought, well, this is a good idea. Very good idea. So I classified my cases according to Takeshi Kawase. And he agreed to this, actually, I contacted him. So this is upper clivus, just the clivus, and this is the attachment. If you look, what's the relationship here with the brainstem, with the posterior clinoid process, with the trigeminal nerve, with the third nerve? It's different from other tumors called cavernous sinus type. So this is the tumor going to the cavernous sinus. So this relationship of this tumor is different from this tumor. So that would help you knowing what kind of meningiomas you are dealing with. Third type is tentorial. Fourth type is petrous. So different relationship with the brainstem and the cranial nerves. So here we are. I classified my 54 cases into upper clivus, 20 cavernous sinus, 15 tentorial, 12 petrous ilex, 7. These are the upper clivus cases, 20 cases. These are all mine. This is the cavernous sinus. You can see that going into the cavernous sinus. Tentorial, they are mainly at the tent. And the petrous ilex, like this one. What was their presentation? Anything, of course, in the posterior fossa can come up with ataxia, level of consciousness, etc. And look at this, depression. Beware of depression in the nervous system. Lots of meningiomas present with depression. And in a study when I was in UK, they went into the mental institutes who found people who were instituted in these mental hospitals. That was in the 85. And they found that 20% of them, they had brain tumors. 20% published by the New England Journal of Medicine. The cranial nerves, of course, they can be affected by what is the commonest? Abducent by location. So I use many approaches, but I love the retrosigmoid approach. But I'm not a prisoner of that approach. I use the petrosal approach, the anterior and posterior and combined approaches and so on. And we do Karnofsky performance for all patients. I love the posterior approach, and we're doing it in the sitting position under the observation of cranial nerve function. Hamza, you are here?
Yeah.
We use for many instruments like navigation and like cranial nerves monitoring to know exactly what we do. As I said, sitting position. We are masters of this. We have done hundreds and hundreds of cases. And this is a case of mine where I use the pre-sigmoid approach. Gross total resection, you cannot remove Simpson grade 1 in posterior fossa. Not me, not anybody, not any master in the world. So you go for gross total resection. If you can't, you do near total resection or subtotal resection. Look at the follow-up. Minimum is 2 years. But look at this. This is the longest follow-up. Morbidity, of course. If you do surgery, you will have complications. The most important that you have a new cranial nerve deficits. And which nerve is that? Mostly the sixth nerve. Surgical results were good, fair or poor. Poor in 4 out of 54. Did I have mortality? Yes. 2 patients died, either during surgery or immediately after, or during the first month of surgery. This is called perioperative mortality. What was, please? Bleeding or dysfunction of the brainstem, basically. You are removing the tumor from the brainstem, and brainstem does not tolerate this. So they remain in coma and they die. What was the histology type? Of course, the cases that Dr. Farsakh mentioned are the cases that are between him and I, that I have cooperated with many other pathologists in the past. So transitional is the commonest, but I had 2 pigmented cases, and this is one of them. Pigmented, removed, came back again. It's called melanocytic malignant type. This is the picture you see during surgery. This is flocculus, choroid plexus, lower cranial nerve, 7/8 trigeminal. So you have to be familiar with this. And this is the severe petrosal vein of Dandy. Again, beautiful anatomy, but you have to master it for you to go and operate on a patient. Look at this beautiful picture. Lower cranial nerve, 7/8 trigeminal, 6th nerve. You're here, you will be operating here. So it has to be built in your brain where to go. Picture that you see. Cranial nerves, when you open, cranial nerves are there, and then the tumor is in front of them. This is a picture where you can see the 3rd nerve going into the cavernous sinus. This is pituitary stalk going to the pituitary. Look at this. This is dorsum celli. The origin of the tumor was here. Here I'm working between 2 cranial nerves, between 7/8 and the trigeminal. So you learn to work between cranial nerves, 7th and lower cranial nerves. And this is the facial, this is lower cranials, and this is the abducens. So surgery can be done, but it has to be done by somebody who knows. And not to refer the patient for radiation because you don't know. Again, a picture that you see in the same position. This is facial nerve, and this is the ICA, and the tumor is in front of you. And this is the end result. Lower cranial nerves, 7/8 trigeminal abducent. So it can be done. Again, beautiful CP angle, free. This is Michel's cave. Did I use gamma knife? I always speak against it. Yes, it's good, but you have to use it in the proper places. I'm not referring patients because I cannot do surgery like they do. So, in the period that I treated these patients 54 by surgery, I used the gamma knife primary. I did not do surgery. I sent them for gamma knife in 9 cases. Or after surgery, they recurred and I use it in 11 cases. What are these cases? Cases that are difficult, but in patients who cannot tolerate surgery. examples. We are covering the name and so on. This is when? Can you read? 2006, okay? This is a tumor. How old? 76, unfit for surgery. 73, unfit for surgery. I treated these patients by gamma knife. This is a patient with this tumor, the so-called cavernous type. Upper clivus go into the cavernous sinus. So I went in, removed all the tumor except that and the cavernous sinus, and we agreed we don't operate inside the cavernous sinus. So I gave this gamma knife, very fair. Or this patient who had previous surgery, somebody removed his temporal lobe. Mediocre surgeon did not accept that he cannot do surgery. He removed the temporal lobe of a lawyer and rendered him really in a very bad state, and the tumor was still there. So I went in and removed as much as possible and treated the rest with gamma knife. I'm presenting to you the images of my series of cases. What did I learn? What can we learn from the images of these patients? CT is very important. Retroclavian meningioma, look at this, calcification. It's important. Tumor infiltrating the vitreous apex. Look at this, tumor destroying the petrous. Here it's eating away the petrous. So CT is essential. So you don't just do MRI and say, oh, there is a tumor, let's hit it with gamma or let's operate. You have to learn more. So CT scan of the petrous bone, MRA, MRV are part and parcel of this management. Look at this. Look at the calcification here. The internal desmoitis is open with calcification. It's MRI. On the MRI, you would see hydrocephalus, although the tumor is away from the ventricular system. It is not blocking the aqueduct of Sylvius. It is not blocking the fourth ventricle, but they develop hydrocephalus. The reason? Meningiomas and vestibular schwannomas, they secrete high protein and they would block and clog the arachnoid villi and they stop the absorption of CSF. You look whether the tumor is unilateral or bilateral. But in this case, bilateral, you have to think of sarcoidosis. I did all the tests for sarcoidosis, it was negative. This was a meningioma, unusual case of mine. Size could be small, could be huge. What is the origin from the clivus? Upper clivus, middle clivus, or all of the clivus? Shape, look at the shape and the nodularity. It's all important. Are they going into the foramen? Yes, they are going into the foramen here. Origin of the clivus as mentioned. Is there any plane of cleavage? Yes, there is a good plane of cleavage. This is good case. Good case. This is bad case. I would love that I disappear or the patient disappear. I don't like to operate on these ones. Look at here or here. So plane of cleavage is important. Look at here. It's no plane of cleavage whatsoever. Why are we looking at this? Because I have to be honest and speak to the patient about prognosis and complications. Relationship with the brainstem. Look at this tumor inside the brainstem, inside the midbrain, inside the pons, and it is nodular. Very bad case. Look at here. Invaginating itself inside the brainstem. Look at here how much the brainstem is affected. They would give gamma knife for this, although the brainstem is finished. They have no hesitation because they cannot operate. So this is the brainstem compression. And I swear to you, swear to God, that I ask them these questions. How would you dare give this patient with a severe brainstem compression a gamma knife? The answer is, I don't care. Nodularity, look at this. This is a bad case, nodular. Nodularity again. relationship with the brainstem causing edema. When you see edema, it means pale invasion has been done. So the tumor is inside the neural tissue and it will end with disaster. They may die during surgery. And these patients, I tell the relatives, your patient may die on table. That's the understanding of these edema cases. Look at here, the edema, severe edema. What about the vascular relationship? Look at this tumor and look at the relationship with the posterior cerebral artery. So you learn a lot from doing the MRA. Look at here, the basilar vertebra is completely compressed by this tumor. Here, it's pushed the basilar backwards. Basilar is inside the tumor. Basilar and its branches are inside the tumor. Please go away, see somebody else. Branches inside. These are all my cases. I'm presenting you the lessons I learned from my cases. Again, this is inside. I would operate, but I would be honest with the patient and tell them what's the outcome. I will show some cases actually. Again, look at here. You don't see the basilar, it's completely gone. So it's important to do CT scan, MRA, MRV. And look at this MRV, you would know, you would envision what is the tumor. Most important. One of my cases, venogram. What do you see? Persistent occipital sinus. That's why you have to do MRV. If you operate not knowing that this exists, once you open the dura, they will suck air inside, whether in sitting position or a prone position. The patient will die out of air embolism. I say, we don't need MRV. Yes, you do. And you need to see what's the superior petrosal sinus is doing, what's the inferior petrosal sinus is doing, what's the cavernous sinus is doing, what's the sphenoparietal sinus is doing, superficial middle vein of Labbe. So many information that we need to know. Venous system, oh, it's nothing. Veins, we cut them, it's not important, and the patient will die. Papers like this, like from Albert Rutten, describing the relationship of the superior petrosal vein with the sinus, important. And this paper from Japan also. So many papers describing the venous anatomy that people do not know. People would sit for the exam, Jordanian board, Egyptian board, Pakistani board, nobody would ask them about venous system. They don't care. Beautiful paper by Assam al-Mifti about vein of Labbe. He called it triangle of Bermuda. You may need to embolize these tumors. And this is one case that I embolized. It's coming from the external carotid, it's coming from the vertebral and its branches. So this is the case, and this is the embolization material. What's the differential diagnosis of these cases? Petroclival meningiomas. Look at this. Huge. Why do we persist in saying this? Because if you just think of meningioma, your brain will get rusty. You will not think of anything else. I will just go through them and ask you to comment. Look at this beautiful differential diagnosis that I came across. Beautiful. If it is extraaxial, if it is intraaxial, if it is in the skull base, T1, T2, the relationship. Let's go through them quickly. Schwannomas, oculomotor, trochlear, they are all in the same place. Schwannomas, vagus nerve schwannomas, meningiomas, of course, jugular foramen, epidermoid tumors, acoustic neuromas, glioma going into laterally like this, epidermoid going laterally like this, chondrosarcoma, giant cell tumor, endolymphatic carcinoma. Yes, they do exist. Hemangioblastoma. They don't only occur here. They're not all cystic. They can be totally solid. Lipoma, glomus jugulare. Oh, it's easy. Let's go in. They would kill the patient. Neurosarcoidosis, treated with gamma knife. Metastasis, the same thing. Choroid plexus, going through the lateral recess of the fourth ventricle. Lymphoma, ependymoma, atypical ATRT, arachnoid cyst, DNET, and so on. Chondroma, chondrosarcoma, I don't want to repeat them. Large cell medulloblastoma, and cholesterol granuloma. You don't irradiate cholesterol granuloma. Remember this, gamma knife is given without histological verification. They don't do biopsy. They just, oh, this is meningioma, let's treat.
So it's the last question.
Can I just finish this and
Please.
I will take your question? Lymphoma, look at this, it looks very much like retroclavian meningioma. Medulloblastoma, histiocytosis, tuberculoma. And look at this paper, beautiful paper, Dorfman's disease. It looks like retroclavian meningioma, yet it was not. Yes, please.
Why do you suspect sarcoidosis in that case?
Typically,
Because
bilateral.
Other than bilateral.
It's the one of the causes of thickened dura, sarcoidosis,
Yes.
TB, post-radiation, post-operative, and so on. So whenever you see the thickened dura, does not mean this is an angiogram. It could be so many. Please.
But again, yani, those were histopathologically proven cases. So the proof actually wasn't the pathology. I cannot emphasize this enough. There is nothing benign about a benign brain tumor. Meningiomas that are not dealt with properly in the get-go, the patient is doomed for a horrible course of recurrent tumors, and that will cause a lot of morbidity and mortality in their life. Now, if I can just emphasize a few points here, where the implications would have been tremendous had this patient received radiotherapy stereotactically with the idea that this is meningioma. Now, imagine if you miss chondrosarcoma and you don't know that the patient has chondrosarcoma. Now, the mainstay of treatment would be optimal resection because really nothing works. Chemotherapy doesn't work, radiotherapy doesn't work. And imagine if you miss a metastases because you haven't bothered to examine the patient properly, and the patient simply had a breast mass that told nobody about, and you just gave her focal radiotherapy to emit in the brain. Now, the implications when you miss a lymphoma that is masquerading as a meningioma are tremendous, because
How many cases did we have last week?
two.
Thank you.
And this is a very rare tumor. Primary cystic lymphoma is really very rare. And I raise my galette and admiration of the professionalism of Professor Speh, who refuses to operate upon cases that he suspects that they may harbor lymphoma, because the treatment of choice would be high-dose methotrexate. And we attempt.
The two cases were given dexamethasone.
Before we saw them. And we continue saying the same sermon. We're preaching to the choir. I know that everybody in this room believes exactly what we're saying. But this pattern of malpractice continues to happen. The problem of giving steroids beforehand is that when you actually get to the biopsy, you may see nothing. And if this mass disappears completely, this is not a good thing, because you can't get the diagnosis. The lymphoma would come back with vengeance and kill the patient. The reason why we emphasize the lymphoma theme, be it particularly primary sense lymphoma, when there would start secondary involvement by systemic lymphoma, is the treatment is so radically different, where the mainstay is high-dose methotrexate in an attempt to delay radiotherapy as much as possible, and it's definitely not surgery. And these cases happen, and they happen masquerading in the most unusual of cases. On the same theme, sarcoid can be missed and can be given stereotactic radiotherapy. And the patient would succumb to something that would have been treated properly with steroids once you have made the diagnosis. And the problem is differentiating pathologically sarcoids from lymphoma may not necessarily be a very easy thing, particularly for patients who were treated with steroids. And I really don't understand the rationale for giving steroids when you haven't had the diagnosis. And if you really are worried about the mass effect, this is why there is something called Manitou, for God's sake. And I'm not talking about life-saving measures where you really have to give the steroids because the patient is impending herniation, etc. I'm talking about things that you really could have bought time by getting the diagnosis. Again, the pattern of mets that are missed is a current theme. Now, when it comes to medulloblastomas and ependymomas, the mainstay of treatment would be optimal resection and then radiotherapy, that may be craniospinal in the case of medulloblastoma. And then, depending on the age of the patient, the adjuvant radiotherapy may be delayed, but for adults, radiotherapy and then adjuvant in the form of platinum-based chemotherapy. And if these patients get stereotactic radiotherapy alone, they're doomed. I mean, these patients are treated with curative intent. Tuberculoma, for God's sake, we are not in Switzerland where tuberculosis does not exist, though tuberculosis does exist now in Switzerland because of the immigration waves. Tuberculoma is endemic in our part of the world, and it's something that's frequently forgotten. And histiocytosis, you let the patient succumb to die of histiocytosis. What happens with stereotactic radiotherapy in the form of gamma knife is that there's no pathological proof. Then these stable things, and the patient would succumb to a mysterious illness that led to his demise. And no, of course, postmortem was not done. And the evidence is buried with the patient. You did not have a proof histologically, and you don't have a postmortem. So how can you tell what on earth happened? And this malpractice continues to occur.
Absolutely. Some of the cases, illustrative cases, this upper clavus cavernous sinus before surgery and after, and this is the operative finding. This lady with the tumor inside the brainstem, Dr. said, I asked, what would you do to this? I tried to push her away. She did not go. She just came to me. I asked her if she can travel abroad. She did not want to. I wanted to travel abroad. I couldn't, so I had to operate. So this is really formidable case. And I operated upon her. She came up with some right-sided weakness, but then she recovered 5 years from now. There's a little bit of something contrasting here, but it is not changing, so I'm not rushing to treat that. 32-year-old with this extensive tumor, before and after. So it is not 1 or 2 cases. This is a school of thought. This very formidable tumor before and after. And the patient. This is the incision. And I always do a small cortical incision here to get the air outside and to be an emergency entry if they develop hydrocephalus. Before and after. This was done surgically. They have not removed the tumor, they have removed the cerebellum. And they say, oh, we'll send her for radiation. Of course, you cannot give radiation to this, so we operated. So even in cases that has been operated before, you still can operate. Before and after, before and after. This lady also, before and after, and follow up. I'll just show you 1 or 2 videos and we'll be finished.
Professor Smith, for you have a question.
Yes.
Is there a line or something you can tell for those tumors that are invading the brainstem? That this is the difference, a line of difference between the tumor and the brainstem. I'm not speaking about the case of the double arachnoid. I'm speaking about the other cases where you are afraid of.
No, you can't.
So what do you do in this case?
I will just go and do my best, and if I find that I'm defeated, I accept defeat. So sometimes you just cannot differentiate.
Thank
you. This is the case where the tumor was inside the brainstem.
Yes.
You see? This is the lady I showed. I went to kick her away, but she did not go. So this is a piece of the tumor inside, but I still could find a good plane of cleavage.
Okay.
So it looked formidable first, but then it went. Okay, let's finish. We'll just show some pictures and you know. Here, sitting position. We are on the right side. This is midline, right side. I'm showing you the trigeminal nerve, and I'm showing you also the sixth nerve inside. This is the tumor. So you work in between the nerves. Superior petrosal vein, vein of Dandy. And here we're removing blood vessels from the surface of the brain. Because you know what they are, because you know the anatomy, and because you know the classification, you would expect where to find the structures. Using the ultrasonic aspirator, here removing the tumor from the accessory nerve. Okay, another one. This is vertebral artery. And this is the tumor, this is the facial nerve. So again, you would have to work between nerves, here between the facial and the trigeminal here, taking the tumor of its origin from the dorsum celli. This is the origin. And in the sitting position, everything flows down, so you have no problem. This is the oculomotor nerve going to the cavernous sinus. This is dorsum celli. This is the origin of the tumor. Once you control that, you have won the case. Here is the third nerve, trigeminal and facial. And here you will soon see the sixth nerve. This little arachnoid here contains the sixth nerve, because I know where to find the sixth nerve. And of course, dissect and resect and so on. So this is then the dorsum celli clear, the stalk going into the pituitary gland, third nerve going to the cavernous sinus. Beautiful anatomy created by the tumor.
Would
But
there
this-
be cranial nerve deficits if you keep?
No,
They would not be.
no. In this way, this patient did not have any cranial nerve deficit. I think we'll finish. We'll stop there. And I just want to thank all the people in this hospital, nurses, doctors, radiologists, everybody, because they are the ones that give me this chance to have successful surgery. Thank you very much. Any questions, any comments? Please, Dr.
لعلك أكثر إنسان في الأردن تذكر كلمة جوكر.
Yes.
قبل أسبوع كنت أنا في لجنة المصطلحات الطبية في مجمع اللغة العربية، وحاولنا نجد المدلول الذي يحاكي كلمة
مدير.
فقلت لهم سأسأل الدكتور إبراهيم صبيح لأنه هو مختص في هذا الكلمة. ما هو المدلول الأدق لكلمة أجر؟
غر ضرير لا مديوكر نو. حقيقة مديوكر هو المهرج، المهرج اللي بنطنط وبدون يقنطهم.
هل نقول هنا شبه جراح، أشباه الجراح؟
يا ريت is much less than that.
رفعنا قيمته.
Absolutely, yes.
ما هي الكلمة التي هي الأصل؟
مهرج.
جراح المهرج.
جراح مهرج. متفلسف. ها؟ كلام. والفيلم تبع شو اسمه؟ تبع جوكر فاز بالأوسكار. They are clowns. Any other questions or comments?
First of all, thank you, Dr. Sbeih. We are lucky to have you with us and this very nice lecture. أنا ما بنسى الحالة اللي بعثت لك إياها مرة 10 years back وكانوا باعتين لي إياها عندنا case of change of behavior. كانت almost my diagnosis هيكون schizophrenia ولو إنه أنا بفحصها لقيت في something wrong فطلبت MRI ولقيت huge frontal lobe tumor وكان بحجم البلداني. وبتذكر يومها دقيت علي قلت له تعال اتفرج شو طلعت لك بالراسها. وناو شيز ا وندرفul lady كانت أستاذة كبيرة والحمد لله كملت حياتها. Second thing, I noticed the change. There is certain patient, there is no changes in their meningiomas. Is there a certain behavior or it's a sort of luck for this?
It's a sort of luck.
Secondly, this patient, if I found this lesion, should she have a treatment, anti-epileptic or anything, or just observe it?
No, just observe.
Okay, thank you. Shukran.
Okay, if not, no more questions, further questions? No. Thank you very much. We'll meet next week.
Wonderful as usual. رغم كل التعب اليوم بس I was very happy to attend it.
Good day, Dr. Sabea.
Good day to you all.
I'm John Bennett from Neurosurgical TV in Miami. Another fine presentation, multidisciplinary. And we have a couple of we had a bunch of panelists, but we have a couple now. I'd like you to meet them, and if they have a
Sure.
question, they'll ask you. Hello, Joanna, could you please introduce yourself to Dr. Sabea? Joanna from Colombia? I hope she's there. She may have stepped away. Anas, are you there? Anas? Yeah, go ahead, Anas.
Yeah, here I want to say hello to Dr. Ibrahim.
Hello, Anas.
Everything is good.
Thank you.
Okay, any questions or comments, Anas?
Really, I don't have a question. Thank you very much.
Okay, thank you for coming. And Joanna, are you back yet? Joanna, are you there? Sorry about that, Dr. Sabea. Okay,
Not at
well,
all.
thank you very much for another fine presentation. What's the presentation next week?
I will inform you tomorrow.
Oh, okay, okay. Have a good week. Thank you very much.
Thank you. The same to you. Bye-bye.
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 Okay, very good. Okay, Anas, where are you from?
I live in Germany.
Are you from Jordan, Anas? Okay. Yeah, let me mute. Okay, they're gone. Okay, I'm sorry, Anas, I didn't hear you. Where are you from?
I live in Germany. I do neurosurgery in Germany.
Okay, what city?
But I am from Jordan.
Oh, okay. So you learned German, and is that the first time you learned German in Germany?
I did learn German in Jordan first. Then I learned the German language better here in Germany.
Okay, very good. Very good. Welcome. And you're welcome to all the presentations. Joanna, you're back? Hello, Joanna, you there? Maybe not. Maybe not. Maybe she doesn't want to speak. That's okay. You have that right. Okay, we're going to sign off now, and you're welcome to come to any of the presentations, okay? Okay, we'll see you next week, if not before, okay?
Okay, thank you. Then next week.
Next
Bye-bye.
week, right. Okay, thank you.
Thank you.
Bye-bye.